first session, it's going to talk a little bit about what was discussed yesterday on quality indicators. I'm going to show you a case example of what we did a few years ago. And yeah, hopefully we'll generate a good discussion. So the outline is first how to use best evidence to guide value-based practice in CRRT. What could be key performance indicators that have been proposed by multiple experts in the field, and then an example of implementation of quality assurance programs, and then if we can use any of these AI digital health tools for CRRT delivery. So this is a good example, the dose of CRRT that we know based on robust clinical trial data that is suggested to be prescribed between 25-30 ml/kg per hour on average. But this didn't happen necessarily in the past, right? So these are the trial data that pretty much make this recommendation a strong level of evidence recommendation, the ATN and the renal trial. The idea was to compare the standard dose of 20-25 of the liver CRRT dose, total effluent, versus a dose of 35-40. And you clearly see that there is no effect in outcomes that are relevant, mortality, AKI duration, kidney recovery. So for that reason, with this data from robust multinational clinical trials, we can say that your dose prescription should be on average 25-30. Now, but if you look into, that's the evidence, it's robust, right? Clinical trials representing a diverse group of patients. Now, when before these trials were done, there were some studies to evaluate from what we are prescribing, if it's around 25 ml/kg per hour, how much is effectively being delivered to the patient. And you can see there was a big gap. The liver dose from the prescription of 25 was only 16.6 ml/kg per hour. And this translated that the patients were not 24 hours on treatment, only 16 hours on treatment. So this gap, that is about 32%, was not considered acceptable. And certainly there were interventions that can be done to minimize these interruptions in treatment, right? So why this gap can exist, a lot of the time has to do patient being off treatment, but sometimes it's interruptions troubleshooting the machine. So important gap, right? Now, we have done much better in those, and this is one of the metrics the data analytics of the devices can track, that is from your prescribed dose, how much you are delivering, and what's the gap between these two. Now, you can see this is data when we tracked a few years ago when I was in Kentucky, and Amy is there, so she was providing all this data frequently. Our gap between prescribed and delivered dose was less than 10%, which was pretty good, right? So that means that comparing to 20 years ago, where this gap was described around 30%, this is a metric that collectively we have improved significantly. Now, experts recommend that your target in this gap should be less than 20. I will challenge yourself even to say it be less than 10 if possible, as it was consistently at UK at that time. But as you know, there was some fluctuation there between 6 and 12% if you see the data aggregated per month. Now, those and that your prescription first is adherent to guidelines that on average said that you should prescribe between 25 and 30, and then that your gap is less than 10% if possible. It's an important key performance indicator of CRRT. And it's easy to track. This is not, you don't need advanced computational resources to track this data. Now, when we talk about factors that can affect solute clearance during CRRT, of course, from our prescribed dose to our delivered dose, there are many things that happen. As I mentioned, there are treatment interruptions. Some of them could be intended, like procedures. Patient needs to be mobilized outside the room, recirculation procedures, and also unintended, right? A lot of the time related to catheter problems, filter changes, bag changes. All that create small interruptions in the treatment, and if you add them together, you're going to have a significant interruption throughout the day. Also, the characteristics of the filter, we lost efficiency, loss of filter surface area due to clotting or air, loss of permeability due to clogging, clotting, absorption, and concentration polarization, right? So your filter, when it's brand new, is not the same in terms of efficiency 3 days later, right? And if you should try to maximize its use up to 3 days, if not more. Now, with this as an introduction that we already have solid evidence in some parameters of CRRT, like those that we can track and see how we are doing, how adherent we are to the recommendations by guidelines, and also what's the gap between our we prescribe and we deliver. So we enter in the stage of what are key performance indicators of CRRT that we can start to validate, harmonize, and then standardize a little bit practice around them. Now, in these studies by Oleska Rewa, through Delphi process. So Delphi process, basically a consensus process by experts that review evidence and provide recommendations. There was a decision to classify key performance indicators based on structure, processes, and outcome. The structure meaning the team, the filter life, the training strategies, processes, all the related to the prescription, time from prescription to therapy, the level of solute clearance, downtime, the delivered dose, the gap, fluid management, etc. And outcomes, of course, outcomes that are relevant to the patients, like adverse events during the treatment, catheter dysfunctions, bleeding, infections related to the catheter, etc. Now, of course, each KPI will have a definition. Just to put a couple of examples, I think we have filter life as one of them. What's filter life, how it was proposed to be defined, is number of filters lasting at least 60 hours from the total number of your filters that you use should be more than 60%, right? So this is the how to operationalize the definition of filter life to say, okay, this is a benchmark that you should target. Now, when you talk with people that track this data, they will tell you filter life fluctuate between 30 hours to 45 hours, roughly, right? So there are people have better performances, others have lower performances. Yes, you may be also in the 20 range, and there is room for improvement for sure there. But in this consensus panel, experts recommended that you should aim for 60 hours as filter life for at least 60% of your filters. Okay, so just to have an idea. Now, I'm telling you that you should follow this strictly. We need to validate this benchmark, right? So to say, okay, this is the standard we should try to aim, and also we need to adjust those to the certain characteristics of the programs, and so on, right? You have other examples. We discussed the delivered dose and the gap from your delivered dose and prescribed dose, the fluid management. In this case, as we discussed yesterday during the workshops, the expert recommended that your gap should be less than 20%. And I show you that's very idealistic because the data show that our gaps are 80, 90%. And I guarantee you that's very common in a lot of practices. Now, so this is what's pending. The conceptualization of the KPIs exists, but how to validate them, and importantly, how to operationalize its implementation is what's pending. And I think this is very relevant because our centers are very heterogeneous. And then perhaps what we need to create is a network where we have hubs that can serve as referral centers for having these benchmarks, references for different centers in the region, and then escalate this nationally. Now, this invites to why we need to have KPIs. So we need to have KPIs to ensure that we can create a process of quality assurance. And this basically means that we need to aim to standardize our protocol to be able to identify with systematic monitoring and reporting of these KPIs problems that are relevant for our practice. And then we need to create a structure that is innovative, where we can implement improvements in CRRT deliverables according to evolving evidence. This is an area with constant evidence being generated. So we need to have a system that can implement those changes. Now, if we summarize what will be essential elements to optimize these deliverables of CRRT, very important, the team. And I think Teresa will emphasize on this. If you don't have number one, that's it. You need to create, you may not have that team assembled, but you need to build it. And build it with patience, with kindness, and being surrounded by the right people. You need to create or update your protocol. You need to have a guidance. So if you go back to your practice tomorrow or Friday or Monday, you should ask, where is our CRRT protocol? I want to see it. When it was written, who wrote it? Is this according to evidence? Do we like it or not? Right? So that's the first step. You need to, what's our guidance here in our practice? You need to create the strategies of education, and these panels, these initiatives that the Baxter Medical Affairs team arrange are very important because it allows you to create a network with people that has the same interest in improving their practice. And this helps a lot. And also, it's one of the forums where there are a lot of nurses. And I have a lot of appreciation and respect for nurses in CRRT because I learn a lot from them. And I think they're essential for the program. So education at the level of ICU nurses, faculty, fellows, and all practitioners in general. Then you need to start thinking in how we prescribe it. Okay, we have a protocol. Do we have an adequate order set? Is it, we can understand it. Everybody really can make this order set or prescribe CRRT easily with no issues in the EHR. So that's important. Sometimes you need to do minor upgrades there that can facilitate the workflow. And then you need to say how we're going to document our CRRT processes. How is our flow sheet? Our flow sheet has been updated when? Can we update it? Yes, you can. And do you have all the elements you want to track? And now with the EHRs being more automated, are those elements sometimes already automatically entered, or the nurses still need to type it? So these are all things you need to start thinking about. And then, of course, how we can access the data, right? This data from these reports, data from the patients that we are treating with CRRT, how we can quantify our practice, operations, how many patients we're providing CRRT a month, what's the total number of days on CRRT, and so on. And then reporting also the back end, right? So this is the front end. The back end is the operations. When you run the program, you need to know how you handle your machines. So what technical support you have, where are the machines stored, right? So who is in charge of that? That's important because when you are in a time like in the pandemic where resources were limited, do we really have capacity to supply our patients in a high demand setting? So if you have this back end structure, you can track your operations on a day-to-day basis, and based on that, you really can allocate resources when are needed. And then you can need to create this system that harmonize all these and can be reviewed periodically. So the teams, of course, this includes all the clinicians, particularly the intensivists, the nephrologists, but pharmacists, nurses, nutritionists, physical therapists, and data analysts are very relevant for the team as well. And the most important thing here is communication. As we were saying yesterday, a lot of the problems start because human beings, we have lack of communication or really inappropriate ways to communicate with each other, particularly when are times of conflict or we need to discuss things we don't think the same way. This process needs to be iterative, so we need to engage the teams. Each team member should have clear roles and responsibilities. Everybody needs to have a way to self-educate and be educated by others in the program, and you need to have leadership support. But leadership support don't start from you going back and say, oh, we need to create a quality improvement program. We need to invest X amount of dollars on it. Leadership support starts if you really create the pipeline vision of the program and you start building the case why this is relevant for the administration. And I will show you some examples how you can do that. Now, problem identification, problem solving, process improvement, this is very important. And this is an iterative process. And the only reason you can continue to make this iteratively if you care about it. You care enough, you will try to improve it. If you don't care about, just find someone else to do it. So, and then let's put an example, right? Now, let's go now to a practical example of our experience building a quality assurance program at the University of Kentucky and how we were able to improve some of the KPIs. So first, we need to understand that there is a lot of data available, but data is not enough if we don't inform any action. And that's why the KPIs are a way to define certain parameters based on data that we can track, and based on those metrics, we can inform our practice. Now, the data come from the device, the data come from the EHR. Primarily, we want to create this structure. And then the challenge is to convert this data into knowledge that can really fit these quality management systems with the ultimate goal to improve patient care. One key element here is the data integration tools. When I created this slide a few years ago, and there was less IT resources than now. So now we have much more IT resources to create data integration tools, even in real time, which creates an interesting opportunity to really develop dashboards that can facilitate our CRRT deliverable. Now, remember, the machine data, and this was discussed yesterday, has programmatic data and therapy data. The programmatic data is filter circuit life related, the time on the machine, the treatment loss, and some complications that the machine record, like access pressures, access alarms, and also clotting alarms. Now, the therapy data is related to the dose, prescribed versus delivered, and related to fluid management, fluid remove. Now, we discussed yesterday the fluid balance gap. The machine only collects fluid remove per hour and in an aggregated period of time, but it doesn't know what was your prescription. That's why the link between the machine data and the EHR is very relevant to understand your gap in fluid management. Now, this is what happened, right? So this was back in 2016. And the reason this started is because I just asked, can someone give me the CRRT protocol? It took about a month to find where was the protocol. And then I noticed that it was written by someone that was no longer at the institution. And the protocol was favoring doing CBBH, and the practice was very heterogeneous. Some physicians were prescribing CBBH, others CBBH-DF. So it was very heterogeneous, unnecessarily, because the evidence doesn't support one versus the other. You just need to harmonize. And so on, different things that were not very in a standardized way for a practice that was an academic practice that perhaps had a lot of potential to be state-of-the-art practice. So we started like that. So then, of course, having access to data from the machines and these reports helped me to see where we were in terms of certain metrics that we can target for improvement. So we developed this team to create this quality assurance program, and then we start to do all these things. So first of all, review our protocol and standardize our prescriptions in terms of modality. So in one of the faculty meetings, I asked if there any preference or for people prescribing CBBH versus CBBH-DF, what's the reasoning behind, and so on. So we agree as a practice that we're going to prescribe from now on CBBH-DF for the purpose that we don't want to confuse the nurses. CBBH-DF give us more flexibility, have an extra pump that you can use, and we decided together that CBBH-DF will be our standardized protocol. And then we make some fine tuning on the protocol, revive our education intervention, re-emphasize our use of anticoagulation. There was still some reluctancy on some of the providers about citrate. We standardized our solutions use. At that time, we were using Foxilon. That was UK decided to have all the practice based on Foxilon. And we started to work also on the flow sheets. The nurses literally were documenting on napkins or their arms, and doing the calculations there. And we said, well, I mean, it's time to build the flow sheet in the EHR. And not only that, we should be able to create the calculations more automated. And initially, of course, there was a pushback because the nurses needed to be trained and have extra responsibility on documentation. But little by little, they start understanding the purpose of why that was relevant. And then also we start looking, and this was a learning process for me on the back end, how the program operates, right? So we had a vendor, for example, that administered our machines. They store them, and we start giving that vendor some responsibilities of providing us some reports about utilization and so on that were helpful, right? So you may have more resources than you think, but you need to orchestrate them with the same purpose. So the vendor was doing their job, and they were doing it probably okay, but they were not creating any report that was informative for us. And that's what we changed. We said, okay, if you administer our machines, you can create a report about utilization that will help me to understand when we are in need or how many times we're about 80% of capacity. And if that's very frequent, then perhaps we need more machines. So that's an informed decision, right? It's not that, oh, I think I need a couple of extra machines. Why we don't get a couple more? Do you really need them? You may need them or not. So these things, right? So the resources are there, but sometimes there is some need to orchestrate and everybody talk the same language, and you can, in the best interest of the program, create positive change. And then the important other aspect was the tracking of these CRRT deliverables. And finally, a very strong push on teaching and training of all the team. Now, this is the flow sheet we created, and this was multiple brainstorming sessions to create this flow sheet and the calculations until we thought that we get it right. This is just a screenshot of some of the reports we get with utilization, and we use some Tableau service to create these reports. And these are the quality indicators that we decided to track, right? Like based on this structure that the Delphi process delivered, that was the process, outcome, and structure of the program. This is a screenshot of some of the members of the team. You may see there Melissa, that is one of our pharmacists, and sorry. And the Amy was there. It's not on the picture, but Amy was providing us a lot of the report from the machine, and great people there that we work together on this program. So now the data, right? So when we started, September 2016, our operations were 20 patients a month, as you can see highlighted there. And as I described, the practice was very variable in terms of modality, CVVH-DF, CVVH. We harmonized this, and it took a little bit of time, but then we agreed that CVVH-DF will be the modality we will use. And then you can see how our operations not only improve in terms of harmonization, but also in number of patients. Why? Because we create a phase for the program. And the phase was not a single person, was a team. And the ICU, in the intensivists start to trust more in the program and call more for CRRT, more consultations. So we really, in a few months, were able to double our operations on CRRT. That was very important. And also, at one point, even at UK, the surgical units, the directors, met with me early when the program was not structured yet, because they wanted to do CRRT on their own. They were not very satisfied with the response of nephrology for CRRT, and they thought that the intensivists can also do CRRT, which they can, but there was no need for, because nephrology was able to take care of CRRT at a high level in that hospital. And that was also something that motivated me to create a program. And we improved some of the metrics, right? Use of citrate, we don't have pre-data because we didn't have any way to calculate it at that time, but our utilization of citrate went up to 73% after the intervention with the education we provided to the clinicians mostly, especially the fellows and the attendings. And the filter life, right? We were talking about filter life a lot. When we started, our filter life was 26 hours on average. We went up in a few months to 31 hours. It may look small, but this was only a few months. And if I heard correctly, I think this has kept going up, as Amy commented to me yesterday, because this is a very strong practice with good use of citrate. access alarms per treatment day, we were able to go down from 3 to 1.7, so almost reduced to half. Just to put some examples of these KPIs that we were able to improve just with a few months of quality assurance. Now, this is the interesting thing, right? So what's the value of this? So, and I'm just going to put the example of filter life. So filter life, as I told you, went up from 26 to 31 hours, and you see the graphic representation there in orange. And the number of filters used per patient, despite the treatment duration was the same, went down from 3.5 to 2.67. So one less filter used per patient. This translates into an improvement in $20,000 per 100 patients. That's calculated based on the filter cost at that time. And if in a practice like UK that had about 600 patients per year, this translates just in about $120,000 savings, just extending your filter life by 5 hours. So this is relevant because at the point that we collected the data and we show that we can improve certain parameters and have cost savings based on this team effort, then the administration start paying attention to us, to the point that when we start, this was people donating their time in addition to what their routine was. Now we have support for a quality improvement CRRT officer at that institution that is supported based on these funds, because the administration believes now that a program that can provide quality assurance with an extracorporeal support device can provide cost savings for the healthcare system, which is true. And this is just putting the example of filter life. So if you, and this is published, you can use this publication when you have these discussions with your administration. So you can say, okay, if our filter life is 20 hours, let's put a goal in 2 years to make it 30 hours. But I need support to create this team and to be able to track some of these parameters consistently. And now finally, in the last few minutes, so these things become more excited because now we have better tools for try to not only use data as aggregated reports to create quality assurance, but we can also use data that can impact our day-to-day operations. So if we integrate the data from the EHR and the devices, and the problem here is not only the integration, but we need to validate this and create some harmonization across practices, we can create these informatics tools for monitoring CRRT delivery. So in the future, just imagine that practices will be able to have some type of support from other centers or more like a 24/7 support to be able to help you on your day-to-day bedside operations, especially for nurses. We can have enhancements of CRRT QI projects. We can have enhancements of CRRT research and outcome measures. And certainly we can create risk classification tools that can personalize care a little bit better. This is an example of a dashboard. This is a good start if you want to create something new in your program. This is from Teresa and Stu from Cincinnati Children's. They created this nice, colorful dashboard. It's also published there. And you can see how, since many years ago, they were starting to track their activity on their CRRT program. And importantly, if you see on the bottom right, they were tracking their fluid management goals and deliverables, which is very important, right? Because as I showed you yesterday, Stu was one of the first showing that fluid overload was a problem in children. And he created a way to track it so the intervention of mitigating fluid overload could be more effectively delivered to children, which is very important. And then, of course, the idea, and I showed you this yesterday, is that we can integrate not only device data or EHR data, but all the data that is available, what is called the data signature of a patient that is in the hospital, including all the monitors, imaging, etc., into creating these models of clinical decision support for augmented clinical decision. Now, when we checked a few years ago with one of our students, the small, like a scoping review of the use of artificial intelligence in CRRT, we found that in these domains of structure, process, and outcomes, there were specifically 7 studies and 3 conference abstracts. This has tripled in just a year and a half. A lot of these studies are related to, they are using AI for data pooling and scheduling allocation of resources. Others are using it for determination of CRRT initiation and pressure monitoring, and others for prediction of outcomes, particularly mortality, hypotension during CRRT, citrate toxicity, and kidney recovery. So this is how the AI is being used currently for CRRT. And as I said, this was published a couple of years ago, so literature is much dynamic than right. So take-home points, many aspects of CRRT delivery are still not fully standardized, and quality assurance programs for the provision of CRRT are not fully developed. Quality indicators of CRRT delivery need to be further validated in multi-center studies, but at least you have a reference where to start. Practice variations and suboptimal integration between machine and clinical data could have a major impact on CRRT delivery. And the use of artificial intelligence can enhance CRRT delivery, facilitate interventions, and potentially impact outcomes. So I hope I just embrace you to create something new when you go back, and just everything you do will make your program better. And I think you have a lot of colleagues and network that can support you during that journey. That is not easy, but it's worthy. Thank you. Questions? Okay. You see, she was surprised. I was done early. So yes, questions, guys, please go ahead. Go ahead. Yeah, I mean, that's a good question, right? So when we talk about extending filter life, it's in an aggregated fashion. Certainly, you have patients are very hypercatabolic, patients that will clog the filter, and that you will need more frequent changes on that filter. Those are the patients that are a little bit an exception of your standard deliverable of CRRT, where you try to maximize your filter use. So, for example, when we have patients with severe rhabdomyolysis, filters sometimes don't last more than 36 hours, and we need to change them more frequently. That's acceptable. So patients that are very hypercatabolic in a very acute state where filters may be changed earlier, it's fine. But when you see still the data in an aggregated fashion, you should have, that's why I said the good quality programs, not separating phenotypes of patients. When you assess filter life, you will see between 40 and 45 hours average. And that includes those exceptions on patients that you can run the filter a little bit more than 3 days.